is the fifth in a series from the voice to AI experts geared towards the future of AI and machine learning workforce to prepare them to work with voice AI. These webinars are hosted by the Skills and Workforce Development Team of the Bridge2AI Voice Consortium. The Voice Consortium aims to integrate the use of voice as a biomarker of health in clinical care to assist in the screening, diagnosis, and treatment of a broad range of diseases. The Skills and Workforce Development Team is comprised of members from both Oregon Health and Science University in Portland and Washington University in St. Louis. I'm privileged to introduce today's speaker, Dr. William Hersh. Dr. Hersh is a professor in the Department of Medical Informatics and Clinical Epidemiology in the School of Medicine at Oregon Health and Science University in Portland, Oregon. Dr. Hersh is a leader and innovator in biomedical informatics, both in education and research. He is also the principal investigator for the Skills and Workforce Development component of the Bridge2AI Voice Consortium, and today he will be presenting AI in medicine and medical education, critical issues, and potential solutions.
Great, thank you, Lisa. And can people see my slides okay? Are they in the right mode?
We see your whole screen. It's not in presenter view.
Oh, there we go. How about that?
Perfect.
Okay, well, thank you for the introduction and thank you all for the opportunity to give this presentation as part of our webinar that is part of the Voice AI project. And I'm going to speak today not really too much about voice, but some of the other issues around the use of AI in medicine and medical education. And I will talk about some of the critical issues and potential solutions. So the objectives of my talk are for you to be able to, by the end of the talk, define the major types of AI and their applications, successes, and limitations in biomedicine, discuss the evidence base for AI, its limitations, and how to improve it, and then discuss some of the issues and challenges for AI in medical education and actually education generally. I don't have any corporate disclosures, but I am funded through the Voice AI, Bridge2AI grant, of which Dr. Yael Ben-Susan from University of South Florida is the overall PI, and I am also funded by several other NIH grants. So probably I don't need to define artificial intelligence or AI, but maybe just a little bit of level setting on one slide. I like to think of AI from this definition of, quote, information systems and algorithms capable of performing tasks associated with human intelligence. And oftentimes we classify AI into two broad categories with probably maybe we could call it the original category of predictive AI. So using data and algorithms to predict some kind of output, such as a diagnosis, a treatment recommendation, a prognosis. And this use of AI goes back into the previous century, and but it has changed in the last decade or so. The newer form of AI that has captured everyone's imagination and attention is generative AI, which is AI that generates new output based on prompts. And so we prompt generative AI for text, for images, all sorts of things. A large part of the modern success of AI, so the 21st century AI, both predictive and generative, comes from machine learning. And machine learning, as probably most of you know, as computer programs that learn without being explicitly programmed. So they basically take data and they learn from it either through supervised or unsupervised or self-supervised methods. And probably the most success in recent years has been through the use of deep learning, which is based on many layered neural networks. And I'm not going to go into that at all, but probably many of you are familiar with deep learning. So let's make a few comments about predictive AI in medicine. And again, people, researchers, others have been trying to use AI for over a half century to try to make predictions, whether it's diagnoses, best treatment, and so forth. And the first era in the 20th century really never achieved its goals, but it's only through the success of machine learning, along with the increasing availability of data. We're awash in data these days, from electronic health records, the internet, sequencing data, images, et cetera. And of course, we have more powerful computers and networks. The breakthroughs, initial breakthroughs in more recent predictive AI have initially were in imaging, and some of that was based on some of the breakthroughs in deep learning, particularly by Professor Geoffrey Hinton, who devised some of the algorithms that make use of deep learning. Those were started to be applied in medicine in the last decade, and I have some pictures on the right of some medical entities, such as the retina, the inside of the eye, a chest x-ray, some sort of biopsy, and a picture of a lesion in the skin. And around 2017, 18, researchers started to develop machine learning algorithms that could diagnose chest x-rays for things like pneumonia or tuberculosis, identify things like diabetic retinopathy and inside the eye, detecting which skin lesions were cancerous versus not, and also pathology. So, for example, predicting which breast cancer tumors might go on to become metastatic. And these were the initial breakthroughs with AI, but it goes beyond imaging. So, for example, some work looking at taking data in the electronic health record and predicting adverse events in hospitalizations. A major problem in biology that was never solved until deep learning was predicting protein folding from amino acid sequences and ultimately the nucleotide sequences. That has really revolutionized protein biology and proteomics. Being able to predict future healthcare use based on ICD-10 codes and lab results. Another interesting application is semantic reconstruction of continuous language from functional MRI recordings. So, in essence, being able to take the activity in the brain and turn that into voice with a fair amount of accuracy. Also, mapping chemicals to odors that we as humans perceive. More back on the EHR front, being able to predict Alzheimer's disease years before its diagnosis. And pertinent to our Voice AI project is using voice as a biomarker. So we have lots of biomarkers in medicine, blood tests, other kinds of things that we measure about patients. Well, voice is one of those biomarkers too. And there has been work at different diseases. There was a systematic review published last year, and the most successes for using voice as a biomarker with AI and machine learning methods in conditions like Parkinson's disease, Alzheimer's disease, cognitive impairment, COVID-19, and others. And I could, and many of you could go on all day and talk about all of the successes of predictive AI. And then when you start to throw in generative AI, it becomes even more accomplished. One other thing that predictive AI can do is see things where us humans are not. I was originally trained in medicine, and I was able to see some things to diagnose patients. But AI can see things that humans can't. And someone who's written a lot about this and a lot about other aspects of AI is Dr. Eric Topol. But for example, AI algorithms can look at images in the eye, in the retina, and determine things like age, biological sex, cardiovascular risk determination, for things that we as humans cannot see. Another interesting aspect, maybe a plus minus kind of thing, because there are potential negative ramifications, but being able to classify race or self-identified race. It's not limited to the retina, no. though. Electrocardiograms, so the same sort of thing, being able to determine age and biological sex from things that we can't see, and that's what the image on the right is showing, but also being able to predict things like chronic kidney disease. It turns out another source of this being able to see things where humans can't is chest x-rays. Race falls in here again, cardiac function and valvular heart diseases. Diabetes mellitus is something that someone devised an algorithm to predict from chest x-ray images. Being able to correlate with chronological age in healthy people, and for those with chronic diseases, the differences between estimated age and chronologic age. And also being able to do the same kind of predictive capability of the common models we use for predicting atherosclerotic cardiovascular disease. So things like Framingham and the American Heart Association have predictive models based on the things we commonly measure, like presence of diabetes, hypertension, et cetera. Well, someone recently showed that you can achieve comparable performance with processing the chest x-ray, again, for things that we as humans can't see. But the real success and what has captured our attention is generative AI. So the ability to answer questions, to take tests and things like that. And while the applications on this slide are maybe not in the long run the most important ones, I think they're the ones that have captured the most attention, probably because they've been so highly successful. So anyone who's listening who is either a medical student or ever trained in medicine took the USMLE, the United States Medical Licensing Exam. And it turns out that generative AI performs extremely well. I sometimes call it the USMLE arms race. The highest performing system so far, and I'm sure others are trying to beat it and probably will, but is GPT-4. That's the most advanced model from OpenAI that's part of ChatGPT. And it's up to now on a standardized test collection of USMLE questions to about 90% accuracy. There was another study just published a couple weeks ago looking at the board exams that all residents finishing residency in Israel take, and they take the board exams to become certified in general surgery or pediatrics, internal medicine, psychiatry, or OBGYN. And you can see the performance of GPT-4 right in there for most of these areas compared to the range of physicians. And for some of them, GPT is even on the higher side. GPT-3, the original GPT that was part of ChatGPT, doesn't do quite as well. But clearly, a generative AI does well on board exams, and it's not just general board exams. For example, those of us who are board certified in clinical informatics, the GPT 3.5 does actually fairly well on that. Fields like radiology, neurology, et cetera. So that's clearly one success. But it's not limited to just board exams. So, for example, there have been many studies, and I list them here, and I have a handout that provides all of these references for those of you who want to go learn more about these studies. But things like solving clinical cases, such as the Clinical Pathologic Conference cases in the New England Journal of Medicine. The large language models do surprisingly well. Some more actual kind of real world kind of applications, even though they were simulated, but how they might be used in the real world. So for example, medical students take OSCE, objective structured clinical exams, where it basically simulates medical practice. And in one simulated text-based approach to OSCEs, a large language model developed by Google called the Articulate Medical Intelligence Explorer outperformed primary care physicians in a text-based dialogue. So it wasn't exactly the same as a doctor sitting in front of a patient, but in things like history taking, diagnostic accuracy, management reasoning, communication skills, and even empathy. Another study also published recently had a similar kind of result, taking 20 clinical cases, giving them to both GPT-4 and physicians and residents, and GPT-4 performed comparable, not only in diagnostic accuracy, but reasoning and including so-called cannot miss diagnoses. So large language models are doing extremely well in more than just answering board exam questions. Other kinds of things that large language models have been able to succeed at, so for example, communicating with patients, so answering questions in public forums, writing letters, or maybe should say drafting letters that have comparable or better empathy, generating surgical consent forms about procedures. And then also kind of bringing it full circle to the predictive AI, being able to classify chest X-ray findings based on previous images and the reports that they use. Also predicting cardiovascular risk from other kinds of data, and a study that was published very recently, proposing synthesizable and structural, hold on, I need to move, structurally novel antibiotics, and actually synthesizing these and showing some capability to handle microorganisms, so potentially giving us new drugs. There are some downsides to generative AI. In last year, every year dictionary.com has a word of the year, and last year's word of the year was hallucinate, because that's one of the things that large language models do. Some people say it might be better to say that they confabulate, but in any case. Another thing that they don't do well, and I'll talk about this a little bit more in a moment, is citing citations. So, for example, I've given you a list of citations for this talk, and systems like ChatGPT and other large language models don't do as well. Coming up with inaccurate or even outright fabricated citations. Another concern about large language models is that they potentially recapitulate what some call harmful race-based medicine. Large language models are trained on the text of the internet and things in the medical literature. If those are race-based inappropriately or ethnicity-based, et cetera, the large language models are going to reflect what's in those systems. Large language models are good at creating compelling disinformation, a task, unfortunately, that humans are good at too. Humans can't distinguish between true and false tweets that are generated by large language models, or for that matter, between those that are written by real Twitter users. So we have this information problem that generative AI may help us solve, but still problematic. Another concern, especially for those of us who work in education, is being able to detect when GPT is used. There have been a lot of studies, and they're all over the map. Some claim they can do it really well, others not. The paper I cite by Tang is a recent overview of the literature, but there are a couple side issues to this. So in general, we can't really detect GPT and other kinds of large language models. One concern is that systems to try to do this detection are more likely to classify non-native English writing as AI generated, which of course is problematic for those who are not native speakers of English. And for that matter, humans are not able to discern AI writing very well either. There are also some downsides to AI in general that we need to continue to address. One is true of really any kind of predictive model. Once we start to deploy these in the clinical world and they start to influence clinical decisions, then that may undermine the predictive ability of such models. And a study by Vade in Annals of Internal Medicine last year simulated this and showed it. Another challenge is even though the systems might work very well, those who use the system may not have the training, or those who develop the system may not have paid appropriate attention to human factors. So for example, in areas, rural Thailand and India, where there is a fairly high incidence of diabetes. And so the ability to do diabetic retinopathy screening to prevent blindness would be beneficial. There were things like challenges of operating the equipment, the workflows in these very busy clinics, the image quality, and the authors concluding there's a critical need for training and attention to human factors. Another issue regards climate change. These machine learning algorithms, especially generative AI, have large carbon footprints. And of course, we may not even know anymore because those who develop these consider their training process to be trade secrets. But clearly, machine learning algorithms, certainly in their training, use a great deal of energy. And so if that is fossil fuel energy, it's potentially adding carbon to the atmosphere and impacting climate change. Another interesting study looked at the electricity consumption of an AI request, so a prompting of a language model versus a Google search. And the prompting of the language model used 10 times more energy. You can consult this paper to see how they came to that conclusion. But it raises the interesting point. Is it worth 10 times the carbon emission to do an AI request versus a Google search? Other kinds of downsides to AI, people are starting to look at things. If someone can, yeah, thank you. Things like automation bias, particularly the way that radiologists, for example, can be impacted by incorrect AI, having detrimental effects on their performance. And then there's this whole area of reproducibility of models. There may be data bias. We've already alluded to this a little bit. There's so-called data leakage, where data from the test set that we're evaluating the models is actually in the training data. This is a concern about generative AI, for example. If we start to ask it questions from the past, are some of the answers to those specific questions in the training data? And then also just the general data drift and shift. I think a good example of this is COVID-19, which is obviously a very different disease now in 2024 than it was 4 years ago in 2020. We've had rounds of vaccinations. We have better treatments for it. We know how to treat it better. And that could be impacting models that we develop around COVID-19. So will AI help or hinder healthcare? There are a number of studies now showing that physicians actually are enthusiastic about AI if it's done from their standpoint properly. But as of last fall, the use of AI was modest. Only 21% of medical groups, only 38% of physicians using explicit medical AI. I mean, obviously everyone pulls out their phone and there's probably some AI going on there, but specific clinical applications. And at least as of last fall, maybe this will change in the near future, but there were other issues that medical practices are concerned about: EHR usability, patient communications, billing, and so forth. And so the question comes up as well, will AI replace physicians and other clinicians? There's a great quote from our colleague Kurt Langlotz, who's a radiologist at Stanford, and he I think puts it well. AI won't replace radiologists, at least not anytime in the near future, but radiologists who use AI will replace radiologists who don't. So physicians and others need to incorporate those tools. And you can plug in your own health profession, whether you're, for example, myself, at least in a past life, was a general internal medicine physician, but nursing, dentistry, et cetera, you can plug that in. And I always like to show this picture, because I'm a Star Trek fan, of Dr. McCoy, who obviously in the 22nd century had great technology, standing in front of some of it, but he always emphasized that he was still a doctor and he was empathetic with his patients and he took care of them. And so there will probably, I hope, always be that need for the human connection in medicine, even if physicians are aided by these AI tools. Some of you may be familiar with the Gartner hype cycle, and it starts with an innovation trigger, and then things hit the peak of it, inflated expectations. They never live up to that initial hype. They fall into the trough of disillusionment and then hopefully reach the plateau of productivity. Well, if you look closely at the current hype cycle, you'll see three of many AI applications: large language models, ambient digital scribes, AI-enabled diagnostic imaging interpretation are at their peak of inflated expectations. And so the question is, how low will they fall in the trough of disillusionment, and will they reach the plateau of productivity? So what do we need to get to the plateau of productivity? So I'm going to, in the remainder of the talk, and hopefully leave some time for questions, we'll talk about three areas that I've been thinking about, writing about, and present you some of my thinking on them, and I'd be happy to hear yours. So one is just this notion of translational AI, translating the AI models kind of out of the basic science into the clinical world, just like we translate molecules that have effects against diseases into drugs. So what's the evidence, and how do we learn about it? We also need to educate the clinical workforce and others, and that's actually part of what our skills and workforce development group in the Voice AI project will be attempting to do. And then a little bit about search systems, because it's actually an area that I've done a lot of research in my career. Will large language models, generative AI, replace doing Google, PubMed, or any other kinds of searches? And we'll talk about that too. And I've written about each of these, and you can find them in the list of references. So how do we show the evidence? Well, those in medicine know we show the evidence by applying the principles of evidence-based medicine, or EBM, where we look for the best evidence to guide us in clinical interventions. The best evidence usually comes from experimental studies, so things like randomized controlled trials, or RCTs, or systematic reviews of those trials. Now, granted, it's not as easy to carry out an RCT of AI as it is to give someone a drug versus an inert substance, i.e. placebo. But still, there are methods that can be used, and there's a nice paper by Liu that looks at some of the issues about doing randomized controlled trials of AI interventions. But like drugs and devices, we need to move from the basic science, which is critically important, but the models that get built in basic science, and then moving them into the clinic, from the bench to the bedside, if you will. And of course, not everything can be studied in an RCT, and we can't do RCTs for every last question that we have, but the evidence can help us. So what does the evidence show so far? So there, if you do a PubMed search on AI, you will find thousands, or maybe now even tens of thousands of papers on models, AI models, and their simulated use. So the basic science, and we need that basic science to create the foundation. And there's even systematic reviews of many of those model papers. But then we need the next step. Can we show that AI works in the real world? It turns out there's a lot smaller number of randomized controlled trials, the clinical science part of this. And in fact, in each of the last 3 years, there has been a systematic review published that basically collates the randomized controlled trials, and they include them and exclude them in different ways, and they pull different information out of them. But we can learn some things. One is that their number is tiny compared to model papers. Maybe we're above 100 randomized controlled trials now, but as of these systematic reviews, that's where we were, depending on how we count them. Many of them, although not all of them, show positive outcomes. So sometimes the trials will not show benefit. I'm going to give you a few examples in the next slides. And many of these trials have what clinical epidemiologists call risk of bias. That is, there are some problems in the methods that raise the possibility that there is risk of bias in the results. So let's talk about a few examples, and we can see where, and again, there are definitely positive examples, but I want to review some of the negative ones so we can learn from them. So for example, one of the most studied interventions of predictive AI is computer-aided detection of polyps in colonoscopy. So when a gastroenterologist does a colonoscopy, looking in the colon for polyps, some of which might be cancerous or precancerous. And this is one of the most earliest and widely studied applications of AI. A recent systematic review showed that indeed AI does find polyps that are missed by colonoscopists. However, the systematic review looked at all these studies and found that most of the ones that were missed were small and clinically inconsequential. In fact, last year, a randomized controlled trial was done of computer-aided detection of polyps and found no increased detection of advanced neoplasias or cancer. So there still may be a role for computer-aided detection of polyps, but the kind of simple use is, at least as of now, hasn't been shown beneficial. Another example is trying to predict hospital readmissions. So we have a problem in the United States and many other countries. Many of the patients who get admitted to hospital were actually recently discharged. I think it's about 18% of all hospitalizations are people who were in the hospital in the previous 30 days. And in fact, in the US, the Center for Medicare and Medicaid Services implemented a penalty for having excessive readmissions. This led to a proliferation of people developing predictive models. If someone can please not talk.
Old Testament, are we?
I don't know if that person can be muted. Anyways, the a number of predictive models, highly accurate, were developed, but they haven't necessarily resulted in programs that actually reduce readmissions. And in fact, there was a randomized controlled trial published last year in taking a high quality model, this was done in Switzerland, and developed a program around it to try to prevent these patients from being readmitted, and it did not succeed in reducing the rate of readmissions. There was also a study done looking at predicting a relatively rare but significant complication in hospitalized children called hospital-acquired venous thromboembolism. So basically blood clots that can break off and cause serious complications. And again, a predictive model was highly accurate, and a trial was done of using the model, bringing in a specialist, a pediatric hematologist, and seeing whether it could reduce the rates of this complication. And the trial showed that there was no difference for the intervention group that had the model and could potentially use it, and just a small educational process. And there were all sorts of issues, one of which is that the primary physicians in the hospital were oftentimes reluctant to use the model. So when it was offered to them, they only used it 26% of the time. Now we can argue, is that a problem for the AI, or is it the physicians, or whatever? But the point is that the model uptake was not that well. There were also instances where the rule would fire over the weekend and the team could not mobilize the specialist to come in and consult with the patient. So even for children in the intervention arm, the AI model was not used, and someone in an editorial said, is this AI's Cassandra problem? The Greek goddess Cassandra, who was blessed with the ability to predict the future, but then cursed with that no one would believe her. And so her predictions were never taken. And then finally, another recent pragmatic clinical trial of a predictive algorithm and the practice facilitation around it for trying to reduce hospitalization from chronic kidney disease. And again, the algorithm was very accurate, but the implementation of it and the practice facilitators did not lower the rate of hospitalization. So how do we get to translational AI? one author describing pediatric critical care machine learning research said, quote, "The literature demonstrates incomplete reporting, absence of external validation, and infrequent clinical implementation." So we need to improve on those things. Some of you know Karandeep Singh, who's now the Chief AI Officer at the University of California, San Diego, and he tweeted in February, "Researched models aren't implemented, implemented models aren't researched." So we need this cycle of implementing models and then researching them in the real world. We also probably need post-market surveillance. Our colleague Peter Emby coined the term algorithmovigilance, kind of a takeoff on the term pharmacovigilance, where the FDA, for example, does post-market surveillance of drugs because the initial clinical trials might be small and we learn a lot more than when the drug is used by the whole population. We will likewise need similar approaches for AI. Our colleague David Dorr, who's part of this project, has written about the responsible use and developing a code of conduct. And in fact, the National Academy of Medicine has released a draft of such a code of conduct for the use of AI. And back to my comments, my blog posting from the National Library of Medicine, the need to build the evidence base. Well, let me shift gears to the second area of concern of what we need to make the next steps. And that's the education of not only clinicians, but also informaticians. So those of us who work at that intersection between in the healthcare system and clinicians. And those of us, myself included, who are educators. And this is actually a topic that I have worked in and written about for a decade. And about 10 years ago, a group of colleagues here at OHSU, we developed a set of competencies. What we believed that clinicians in training, we were focused on medical students, but it really applied to any kind of clinical students, need to know about informatics. So we talked about being able to operate the electronic health record, being able to use search systems, to use clinical decision support, protecting patient privacy and security, professionalism, patient safety, quality measurement, health information exchange, exchange of data from different healthcare systems, engaging patients to improve their care and their use of personal health records. Again, professionalism. We even talked about telemedicine. Of course, this was years before COVID when the use of telemedicine was small, but clearly in this day and age, all clinicians who interact with patients need to know how to do so virtually. Applying personalized or precision medicine, participating in research. And so our initial list of competencies had 13. And then in recent years, initially we talked about data analytics and machine learning. Now the 14th competency is just AI. So being able to use and critique AI applications in clinical care. We're not the only ones who have talked about this. Others have talked about clinicians need to be prepared to practice in a world of AI. Medical schools, like the one we're part of here, face these kind of dual challenges of teaching about it in practice, but then also adapting to its use, not only by learners, but also faculty who are delivering care. And the impact on education, especially of generative AI, is enormous. And I'll talk about this in a moment. And it's not limited to medicine. For example, generative AI can write computer programs. It can create data science workflows. It can create legal briefs. And many of us who are educators are now trying to figure out how do we assess students when they can very easily go to ChatGPT or pick your other favorite large language model and get a lot of what they need that we want to assess. And in fact, one of the most prolific writers on this topic is Ethan Mollick, a business professor at University of Pennsylvania, who has a Substack and very insightful. Anyways, he wrote last year about the homework apocalypse, the challenges of how do we give students homework to make sure that they not just get the large language model to spit out the text at them, but understand what's coming out of them. And I'll talk about that in a moment. In addition to competencies for healthcare in informatics, others have gone further and written about competencies for AI. And in fact, our Voice AI summer school that we're developing, we're organizing the curriculum about this set of around this set of competencies. So basic knowledge of AI, social and ethical implications, how clinical encounters are enhanced with AI, evidence-based evaluation, workflow analysis, and just the learning and improvement of clinical practice using AI tools. So back to Professor Mollick, who's also written a book called Co-Intelligence, who for really viewing this from at the standpoint, we can't ignore it, but on the other hand, we need to adapt to it. So he wrote last year about assigning AI, and so his 2023 paper talked about all the different ways you can apply and use generative AI as a mentor for students, as a tutor, a coach, a teammate, a student. Actually, you can see how well it learns from you, a simulator, and really a tool. Although also noting that there are risks, the confabulation or hallucination risk, the bias from the training content that we alluded to earlier, privacy risks in terms of whether AI could uncover people's privacy, re-identify them, and then instructional risks, students over-relying on generative AI. A more recent paper looked at innovating with AI, and I mentioned that Professor Mollick has a Substack, which you can subscribe to like I do. And a recent paper, he took these use categories and started to talk about specific things you can do: simulations, critiques, teaching, co-creation, mentoring, and so forth. And so these are probably the kinds of things that those of us who are educators need to do with generative AI going forward to be able to assess our students. In fact, I don't expect anyone to read this all, so I've provided the link to you. This is a policy I've developed. Many of you know I teach a highly subscribed introductory course in biomedical and health informatics. I'm not going to put my head in the sand and think that students are not going to consult generative AI. So I've developed a policy. For example, this course is taught online. There are discussion forums. There's very interesting discussions that can take place. I really prefer that students not go get stuff out of generative AI, ChatGPT, whatever, and paste it in. The discussion is meant for discussion. Maybe the generative AI can inform the discussion, but the discussion is really meant to talk about things. Likewise, for some of the student assessments, we do this by the honor code, but that you can interact with and quiz generative AI, but not to use it directly. I have historically given students open book final exams. I'm actually questioning that. We'll see what happens going forward in the future. But I think we're all going to need policies like this to figure out how to use generative AI in education. The last area I'll comment on briefly about search systems. So I mentioned that this has been my area of research back to the days before Google. How do we help people find information online? I, like everyone else, enjoy playing with ChatGPT and other generative AI systems. But I know that when I do a search, whether it's because I want to cite something in my teaching or when clinicians are in practice, we need more than answers. In clinical care or research, we want to know methods and insights. For teaching, we want to synthesize knowledge for our students. So where the information comes from is as important as what it says. In fact, if you go back to the original definitions of retrieval systems from the last century, it was stated clearly that they don't inform the user, but instead they point the user to information that would help them find what they're looking for, answer their questions. So Lancaster used the term documents. These days we might use things like articles, web pages, videos, etc. But search is still important. And some of the concerns we have for searching, one is, and this paper by Chirag Shah that talked about some of these issues with search systems and potentially using large language models in their place. So the opacity and hallucinations. Large language models often don't know when they don't know. Large language models, you can debate this, and I know that there's several court cases that are going to debate this. They're stealing content and website traffic from sites. Should there be royalty payments? How should we control that process? And then another issue is that learning is serendipity. I've certainly learned things that I didn't set out to learn because I was looking up something else. So searching is exploring, and do we want to completely give that up? Another issue that's come to the fore more recently is whether the output from large language models is starting to contaminate the scientific literature, the peer review process, and you can see here that depending on the field, depending on a number of other things, how much of what is in the literature now is generated by generative AI, and is that a form of contamination? You can argue that. And even the peer review process, someone recently studied peer review and found a similar sort of thing, that people are using generative AI to do peer reviews. Another issue is, well, so I mentioned in a slide ago, a couple slides ago, about when we search, we don't just want the answer. Who said this? Where are they from? What did they do to come up with what they stated? What were their research methods? And it turns out that at least now, large language models don't do a real good job of citing their references. So certainly when I have students write papers, for example, I want them to cite the references for the claims that they're making. A recent study by Wu found that large language models, and you can see the figure on the right, don't necessarily give you valid URLs for their source attributions, and they don't necessarily provide support either at the individual statement level or the overall response level. And the one that did the best here was the Microsoft Copilot that uses this technique called retrieval augmented generation. So its URLs were pretty good, but its support at the statement level and response level, while better than the other large language models that they looked at, was far from perfect. And you can see the percentage of the different systems. So I will make some conclusions here and hopefully leave some time for questions. So what do I conclude from all this? Well, certainly AI will profoundly impact how medicine is practiced, how we teach health professionals. There's no question about that. Translational AI is a necessity and an opportunity for clinicians, researchers, and others. I certainly tell students that probably one of the most fruitful areas of research these days is this kind of translational step of AI, how we take the models and actually implement them in the real world and study them and see if they make a difference for patients or healthcare systems or whoever. So another conclusion then is that healthcare informatics and educational professionals must be competent with AI, just as much as any other tool that they use for clinicians, tools in their clinical practice that they use. And generative AI systems must give us more than just the answers. We need to know where the answer came from, how it's supported. We might even want to know some of the pros and cons. And so that is important as well. So I'm going to wrap up here. As Dr. Karsten said when she introduced me, I'm a professor at OHSU. I have a website where there's actually a PDF of these slides, though I think they'll probably go on the Voice AI site as well. I write a blog. I've published a textbook about health informatics, and I also have a website itself called What is Informatics? So I will stop at this point and be happy to take any questions.
If anyone has questions, they can raise their hands or unmute themselves to ask.
I also see one in the chat from my colleague Bob Hoyt. What do I see in the future for the EHR integrated with AI? That's a long question. And there's all sorts of other issues. For example, as most people in the know tell physicians and medical students, you should never put protected health information into a public large language model because that information might become part of the model. But certainly, I mean, we saw from some of the studies I presented, the ability to converse with AI, to maybe get AI to tell you about diagnoses you should be thinking about, things you shouldn't miss, maybe to make treatment recommendations, although the models may not always be absolutely completely up to date, although if they can do retrieval augmented generation, they could potentially incorporate newer studies. So I think it's a complex picture of what the EHR integration with the EHR is going to offer. I see another question. One consequence of AI as a competency is that many or the majority of practicing clinicians are likely deficient. Apart from personal interest on an individual basis, how can we assure a basic level of competency? Well, certainly for those in training, it needs to be part of the curriculum, just like any other tool. You learn to use a stethoscope. Just like 15 years ago, David Sackett, the father of evidence-based medicine, said that the search engine is just as important of a tool for clinicians as the stethoscope. And perhaps sometime soon, generative AI will also be as important as the stethoscope for clinicians. So certainly part of medical education or health professions education. But then for practicing clinicians, I mean, most clinicians these days have to do continuing education. For physicians, it's continuing medical education, but other healthcare professionals need to keep up. I mean, just like you keep up on the latest diseases and treatments and so forth, this needs to be another thing that clinicians keep up on. And even those who work in informatics, AI needs to be a broad part of the informatics professional curriculum and their continuing education because they're going to be the ones implementing these systems and trying to figure out how to get them to work effectively.
I don't see any more questions, but I do have another one. You know, is there much work being done in like creating models that can reference themselves accurately? Like that seems like something that's kind of needed if they're going to be used for informing something as important as healthcare.
Sure. I think that's an important area of research and development. And I think it's important in fields like medicine, where, like I said in my lecture, if someone says something about that this test is required, I mean, I think of it in my own, as a patient. I would like to think that the clinician who's caring for me, wants to know when some generative AI system says, do this or think about this diagnosis, where does that come from? One of the challenges is that the large language models are so um, intense, requiring processing, of their training data, not to mention the carbon, the potentially that they generate, but the training data, and then they get trained, and then they're used. For example, GPT-4 was trained a year ago. Now I know that there's ways to add more into it, again, retrieval augmented generation, other kinds of approaches. But I think we need to evaluate those sort of questions from a research standpoint, and how do we make sure that even though maybe medicine isn't changing quite as fast as AI, but medicine does change pretty quickly. New treatments, new diagnostic tests, and so forth. And so that area needs to be evaluated as well. And another question just popped into the chat. So since we still have a few minutes, if publicly available health-related data, for instance, publicly available social media channels or posts, is entered into ChatGPT, would that be more permissible? I'm not permissible from a privacy standpoint. I actually see some real challenges for models relying too much on social media. I'm as much of a social media user as anyone. However, I'm not sure that social media is the best source of information. It can be, and I certainly follow a lot of medical AI leaders on Twitter and keep up with the literature that way. But we also know that there's a lot of other stuff on social media that I'm not sure we want training large language models. I don't know if that answers the question.
There's also a question from Vishnu that's above that one.
Oh, I didn't see that. Okay, yeah. How do we get around the challenge of effectively evaluating AI products in healthcare when they will be, for the most part, black box software? Yes, this is a big concern. In the old days, when we didn't have these huge, intensive, models that were intensive to train, we could do everything in our labs. And we could build, we could take data sets and use machine learning tools and tweak them in different ways and so forth. But now systems like ChatGPT, Gemini, Claude, et cetera, we have really no insight into. They are black boxes to us, and we prompt them, and it's important for us to know how to prompt them well. But we don't know. And for example, as one of our fellows under your purview, Dr. Kernberg showed that, and others have shown as well, that different information comes out at different times. So this is an issue, in terms of reliability of experiments and things like that. So it's a definite challenge, and we probably need really good frameworks for describing how we study large language models, so that we can understand the research as much as possible. So I guess I'll keep going until we run out of time. Bob is asking, will we have to rewrite HIPAA if we can identify? Yes, this is a big issue. Well, right now, there's, at least in the general models, there's not, I shouldn't say that really. There's not that much protected health information, though we know there is some. And in fact, there's a whole line of research about jailbreaking large language models to get personally identifiable information that when all of the entities that have large language models use this process called reinforcement learning from human feedback to try to train the models not to answer questions that reveal personal information or make racist, sexist, other kinds of comments. But many researchers have shown that you can jailbreak those models and get them to give you the kinds of things that you shouldn't necessarily be having. So whether we probably need to rewrite HIPAA for a number of reasons, not the least of which is protecting information that flows outside the healthcare system. Maybe I'll answer this one last one from Dr. Orwell. Are humans not the ultimate black box? I mean, I suppose we're a black box, but and we don't know everything that goes on in our brains, but you can study people and there's some amount of reliability. I mean, I'd like to think if you asked me something I knew about that, my answers would be relatively consistent. But that is a good point. And Kate mentioning having closed models. So yeah, models, once they're trained, moving them into a closed setting so that any protected health information that goes into them, and Children's is not the only one, but there are a number of hospitals doing that, where they're licensing large language models, running them inside their networks so that the training doesn't go back to the producer of the model. So I think we're probably out of time at that point, so I will turn it back to Lisa.
Yeah, we're out of time. Thank you all for the really great talk. Thank you, Dr. Hersh, for the really great talk, and thank you all for joining us today. I hope to see all of you at our next Voice to AI lecture. Have a good one.
Great, thanks a lot.